Yeah, welcome back as always, welcome to the channel. Thanks for watching. We're doing our best with ultrasound. You know, we're not the ultrasound experts, but we're using it every day. We're building skills. We're trying to ultrasound every person that we can. So pretty much everyone that comes in that looks like they could use a scan, we do. Musculoskeletal ultrasound, I think, should be the first type of ultrasound, first sort of system of ultrasound you learn. It's simple, instant results, and instantly applicable. So much of our general practice is musculoskeletal. Have a young man's popped in with a slightly sore knee with a lump on the front of the knee. We'll just have a look at the knee, just quickly there as you look down with the, so here's the knee here. You might not see very well, but there's sort of a lump in the prepatellar region. There's the kneecap, there's the prepatellar ligament, there's the tibia. Just sort of a lump there. Of course, we might, we have a fair idea what that could be. It's a bit tender, not too bad. It's fluctuant. We suspect it might be, maybe it's a bit of bursae. Could it be an abscess? Probably not. Could it be a lipoma? Probably not. But still, it looks like it would be a fun thing to scan. So let's do that. We've got our little butterfly handheld, which, but all the handhelds these days are pretty good. Tons of gel, remember? We're using tons of gel. The more the better. And then we're just going straight on. Just go straight on to the thing. Let's have a look, and we'll just point the screen a bit that way if you like, a bit out there. And the first thing is you try and get a decent picture. So let's start off with seeing something we can recognize. Get your picture looking good. There's the patellar ligament. Remember, like a paintbrush. There it is. Skin up the top, make it a bit bigger. There's the ligament, like a hammock. And then we go up to the kneecap. All looks pretty normal, doesn't it? So the actual ligament itself is okay. There's no history of trauma here. And then it's joining onto the tibia there. Remember, you can't see into bones. You just see the surface. Anything underneath a bone is just reflection. And we don't need anything that's below our area of interest, we don't need it in the screen. So maximize your screen. You see a little black area up here. That's putting a bit of pressure. You can sometimes get caught out. If you put too much pressure on, you might miss something. See, it looks like there's nothing there. If I release the probe a little bit, I've got the probe on longitudinally. If I release it a little bit, there we go. So we've got a bit of a hypoechoic area there. So let's have another look. So there's the tibia, there's the attaching patellar ligament or tendon, whatever you want to call it. Maybe a bit of calcification in there, don't know about that. But anyway, as we go up, then we get into this, and we're just running out of gel. We get into this area. Here we go. As we're on top of the patellar tendon, there's this dark area. If I push down with pressure, I can squish it. So it's fluid. All fluid looks pretty much the same, whether it's blood or urine or breast milk or pus. It just looks darker, and you can squish it generally. So that tells us, and it tells us it's above the patellar tendon. It's not coming from the joint. We can't find any connection. Just sort of scrolling across. So that's like a bursae just on top of the distal end of the patellar tendon. You would have diagnosed that anyway through your clinical acumen, of course. But this is just an example of things that we can add to our study. And if we want an objective measure, you know, we can, of course, just put freeze that, do a measurement, you know, and we can say, oh, you know, this is how big that is. 4.2 millimeters, that's the kind of the depth of it, whatever. And we could measure the longitudinal distance as well. If you want an objective measurement, you want to know, is it getting better over time? You can re-measure it. Is it getting worse? This is useful for abscesses or other things that are a bit more important than this particular example. So I think what we've got here is that we've just got a confirmation of the diagnosis. Right, there it is there again. We can go transverse, so turn the probe 90 degrees, and then we'll see the patella tendon and transverse, and if we go down a bit, we'll see a bit of fluid on top of it. Here it is there. So I'm losing contact. You see there's the fluid on top of it there. So that's, and there's the tibia with the tendon attaching. So that's the thing. So this is not critical, is it? But it's an example of how we can objectively measure some things. We can confirm our diagnosis. We've got our ultrasound scan beside our bed or on our desk, turned on, ready to go the whole time. Why not just use it? You can always compare the other side as well. You know, have a look at both sides and just get used to seeing these differences in anatomy from the normal to the abnormal. So once again, thanks for watching. That's a little bursitis to add to the mix. See you later.